Hello, good morning, everybody. I am Siddhartha and I'm a clinical associate professor in the Department of Radiology at the University of Alabama School of Medicine and Veterans Affairs Medical Center in Birmingham. I would first like to thank Kavita Madam and Vijay Bhaskar Garu for giving me this opportunity to speak in CREST Society. And I welcome everybody to this meeting. And today I will be talking a bit about imaging of movement disorders. And we will talk about what we actually know or claim what we know. And obviously there's a lot of puzzle over here which we do not know. So let's start our introduction by characterizing what movement disorders actually are. These are neurodegenerative disorders which are characterized by a combination of tremors, rigidity, and akinesia, which is just difficulty in initiating movement and weakness. If you actually look at the most common cause of these conditions, it is most likely benign essential tremor and drug-induced Parkinsonism. But although these conditions are very common, they are not classified as a neurodegenerative disorder because there is no intrinsic pathology in the brain. The most common neurodegenerative disorder which actually causes movement disorder is actually idiopathic Parkinson's disease. And the current role of imaging right now is best described as a moving target. So if we talk in detail about Parkinson's, it's again, as I said, the most common movement disorder with intrinsic pathological changes in the brain, and it is marked by bradykinesia, tremor, rigidity, and postural imbalance. Now, there is a differential diagnosis to Parkinson's disease because it is not the only movement disorder. There are other movement disorders, as we discussed, benign essential tremor, which is actually the most common movement disorder. And there is drug-induced Parkinson's, vascular Parkinson's, and there's a whole gamut of spectrum of disorders called atypical Parkinsonian syndromes, and we'll actually talk about them in detail in this lecture. The atypical Parkinsonian syndrome, or APS as we will abbreviate them, is characterized by a group of heterogeneous disorders, among them multisystem atrophy, progressive supranuclear palsy, dementia with Lewy bodies, and corticobasal degeneration. Now, these disorders can mimic Parkinson's, but clinically have frequent falls, dysautonomia, bilateral symptoms, and fail to respond to levodopa. Now, before we actually go into the details of their imaging, it is actually very difficult, and I cannot speak from a neurology perspective, but early in the course of these diseases, all these syndromes, where it's atypical Parkinson syndrome or idiopathic Parkinson syndrome, actually manifest with similar clinical symptoms, and it is very difficult to actually separate each individual syndrome unless the disease goes into the advanced stages. And we all know that treatment is most effective and really required in the early stages. So our question is, can imaging actually help in early characterization of these movement disorders? And the answer is right now very ambiguous. So if we look at what exactly is happening in these movement disorders, it's a spectrum, the neurodegenerative changes pathologically which occur in Parkinson's also occur in other neurodegenerative disorder. It is actually the location where these changes are predominant which actually determine each individual neurodegenerative disorder. So this is an image of the basal ganglia and its connection to the substantia nigra. The substantia nigra is actually a gray matter nucleus, which is actually situated in the midbrain. And the substantia nigra sends connections to the basal ganglia, which is the caudate and lentiform nucleus, and they also send some connections to the globus pallidus. Now, in patients with Parkinson's disease or any other neurodegenerative disorder, what actually happens is that these pathways degenerate and become less in number. So this is not just a pathology which occurs in Parkinson's disease, but also occurs in the atypical Parkinson's syndromes. And if you look more in detail into the pathology, there is a deposition of Lewy bodies which happen in Parkinson's disease. And Parkinson's disease, as it becomes more advanced, can present with Parkinson's disease with dementia, or you can also have another totally different entity called Lewy body dementia. Multisystem atrophy has alpha-synuclein deposition, whereas progressive supranuclear palsy has tau protein deposition. Now, it is probably not that important for us as radiologists to know what exactly is the pathological marker of each individual disease, because there's a lot of overlap between the different pathological markers and the different diseases. But it's very, very important to know that levodopa and deep brain stimulation best control symptoms of Parkinson's disease and are not completely effective in the other movement disorders. Now, what is the role of imaging? First of all, if a patient actually has characteristic symptoms of idiopathic Parkinson's disease, they typically don't require imaging. They are treated with levodopa. So there is no current role of imaging for these patients. And these patients are probably a big subset of patients. When do we actually require imaging? Imaging is done when patients have atypical symptoms or poor response to levodopa, suggesting another underlying condition which should be determined. The modalities of imaging include MRI, FDG PET, and then you can also do a PET with amyloid tracer agents called 18-fluorine-fluorobetaper, or you can do a SPECT with an I-123 DAT scan. And the I-123 DAT scan, among all these modalities which we are talking about, the DAT scan is actually a very specific modality which actually targets specifically the dopamine transporter in basal ganglia, and it's a very sensitive technique. So this is a very specific dopamine transporter study. Now, there are various PET agents which are also specific for dopamine transporters, but they're not available currently widespread in clinical utility, and they're mainly for research. So our current dopamine transporter agent is actually a SPECT agent, which is I-123 SPECT. So what is the MR technique? Because most of the patients who actually have movement disorders don't get a PET or a SPECT. Those are actually considered even secondary techniques, but most of them actually come for an MRI. So what is our MR technique when we actually are trying to diagnose or follow up a patient with imaging disorder? Number one, we do a non-contrast technique, and contrast can be administered if you're looking for inflammation or infection, but typically not recommended. The most important thing is to do a 3D MP range T1 sequence, and this is the sequence we also do in our dementia protocol, and this is looking for the specifics of the type of cortical atrophy. Remember that not all patients with Parkinson's disease actually have Parkinson's disease. They actually can have an underlying dementia, such as Alzheimer's. So it is very, very important to assess the cortex to look for any cortical dementia. Now, susceptibility-weighted imaging is the hallmark or the key for looking at iron deposition in the brain and to look at the substantia nigra. And this technique should never be omitted from any patient who you suspect a Parkinson's or an idiopathic, an atypical Parkinsonian syndrome. Now, there is a lot of there's a lot of research onto diffusion tensor and spectroscopy, but we typically do not routinely perform them in patients with movement disorders. So let's look at the susceptibility-weighted image. So if you look at MRI in idiopathic Parkinson's disease, and 1.5 Tesla, if you do an MRI on 1.5 Tesla, it typically is normal. In advanced cases, you can demonstrate cortical atrophy. Now on 3 Tesla, you can actually look at the substantia nigra, and if I will actually show you a normal patient. So in a normal patient or in a patient with atypical Parkinsonian-like symptoms, you actually have what is called a swallow sign. And let's look at what this swallow sign is. So this is the normal substantia nigra, and it actually has a fork-like signal at the posterolateral aspect. And between this fork-like signal, you actually have a white matter hyperintensity, which is actually the intact nigrosome. And that is actually seen in patients who have atypical Parkinsonian syndrome, or actually it's just in normal patients. In patients with Parkinson's, this healthy nigrosomes degenerate. And while degenerating, they are filled with iron. And as we all know, iron gives a dark signal on SWI. So you lose the swallow sign or you lose the fork, and this is what you see in Parkinson's disease. Now, it can be asymmetrical, it can be unilateral, or it can be bilateral, but that is the most sensitive and specific finding of idiopathic Parkinson's disease on MRI. Now, let's talk a bit about the I-123 eye flow pain scan, which is called a DAT scan. And why do we do this? So remember that the DAT scan is very, very specific for dopamine transporter in the brain. So it actually, I'm going to move my image slightly higher up so that you guys can all see the dopamine transporter study. So this study is very specific to look at the dopamine transporter cells in the basal ganglia. And as we all know, in Parkinson's and in atypical Parkinsonian syndromes, it is the degeneration of these dopamine transporter cells. So this is what we call as the comma-like signal in bilateral basal ganglia, which is the putamen lentiform nucleus and the caudate nucleus. In patients with Parkinson's or idiopathic Parkinson's disease, there is loss of the dopamine transporter cells and loss of the signal from the HMPO, sorry, I apologize, from the I-123 eye flow pain in the basal ganglia. It starts in the putamen and spreads to the caudate nucleus. The process can be asymmetrical, as we all know that Parkinson's is an actually asymmetric disease, okay? It starts on one limb and it progresses to the other limb, so the changes can be very asymmetrical, okay? Now, this study is mainly done to differentiate between Parkinson's and benign essential tremor and drug-induced Parkinson's. In benign essential tremor and drug-induced Parkinson's, as we know, there is no neurodegeneration of the dopamine transporter cells, so the activity is preserved. But this study cannot differentiate idiopathic Parkinson's disease from the atypical Parkinsonian symptoms. Now, multisystem atrophy. Let's talk a bit about multisystem atrophy. Multisystem atrophy was previously called Shy-Drager syndrome, and it mimics Parkinson's, but it has a greater autonomic dysfunction in such that patients actually have orthostatic hypotension, they have urinary incontinence, and there is significant neural loss in the basal ganglia. So there's significant degeneration of the basal ganglia compared to idiopathic Parkinson's disease. It is of two subtypes, MSA-P, which mimics more of Parkinson's, and MSA-C, which has more cerebellar symptoms. So MR is actually good in actually differentiating MSA from Parkinson's disease later in the course of the disease. And if you look at this cerebellar subtype, which we're going to show you over here, this is MSA-C, which is olivopontocerebellar atrophy. You actually have atrophy of the pons and the cerebellar peduncles, and you have this what we call as a hot cross bun sign, which is degeneration of the transverse pontocerebellar fibers. Now, the hot cross bun sign is a very specific finding of MSA-C type, but it is not very sensitive. Then some studies claim 80% sensitivity, and some studies actually claim only 60% sensitivity. But when this finding is seen in conjunction with cerebellar and brainstem atrophy, it is actually a very, very specific sign of multisystem atrophy C-type. And multisystem atrophy P-type is actually a bit more difficult to diagnose on MRI, but there is significant degeneration of the basal ganglia in contrast to Parkinson's disease. And we see what is called as a putaminal rim sign. There is actually degeneration of the nuclei within the posterolateral putamen, as we see over here. And that's the sign seen on T2. On SWI, there is decreased signal within the putamen, which is seen in MSA-P, and that is decreased signal is due to increasing iron deposition and degeneration. Now, the DAT scan in MSA does not actually differentiate this condition from idiopathic Parkinson disease, and as we are actually demonstrating over here, there is decreased signal of the eye flow pain in the basal ganglia. Now, FDG PET can differentiate between MSA and PD, although it's not routinely done over here in our institutes. But as we discussed, I don't know if I really discussed, but the basal ganglia become very hypermetabolic in the atypical Parkinsonian symptoms, in contrast to Parkinson's disease, where the basal ganglia retain their normal metabolism. So if you look at this FDG PET in Parkinson's disease, note that there's normal activity within the caudate and the lentiform nucleus, but in this patient with MSA, you actually can see the decreased activity. So FDG PET can be used as a problem-solving tool when there is a specific diagnosis or when there's a specific need. Like I want to differentiate between MSA and Parkinson's disease. Yes, you can use an FDG PET. Let's talk a bit about progressive supranuclear palsy, the next condition in our basket of atypical Parkinsonian syndromes. So progressive supranuclear palsy presents with Parkinsonian-like symptoms, but it actually has a vertical gaze palsy, and that's because of the midbrain atrophy. In the midbrain, you actually have the trochlear nerve or the fourth cranial nerve arising. So because of the atrophy of the midbrain, you have a vertical gaze palsy. Patients have more of a truncal ataxia than limb involvement, and unfortunately, there's no specific treatment available, just like in MSA, and they respond poorly to levodopa. So this is what is called as a hummingbird, and just look at the hummingbird and the beak, and this is the midbrain, and that's the pons of the hummingbird. So there's midbrain atrophy. So we spoke about pontine and cerebellar atrophy in MSA, but in PSP, we actually have a midbrain atrophy, and there is also superior peduncle atrophy. So there are some signs called the Mickey Mouse sign, which is the reduced AP diameter of the midbrain. So the cerebral peduncles are actually spared, the tectum is spared, but it's the ventral tegmentum right anterior to the aqueduct which is atrophied. So you get a Mickey Mouse sign, which is a reduced AP diameter in the median midbrain. Note the sparing of the cerebral peduncles. And we have hummingbird sign on the sagittal view, where you actually have a small midbrain with a flat or concave superior surface, and the midbrain is actually reduced in volume compared to the pons. So we can use a DAT scan, and the DAT scan, just like Parkinson's, actually will show symmetric or asymmetrical reduced uptake in the basal ganglia. Not useful to differentiate it from Parkinson's disease, but definitely we can differentiate this from a benign essential tremor. And if you look at the sagittal T1s in Parkinson's and MSA and progressive supranuclear palsy, notice that the T1 images are, most of the images in volumetry, where you have to look at volumetry, are normal in Parkinson's disease. In MSA cerebellum type, there's atrophy of the pons, whereas in progressive supranuclear palsy, the pons is actually intact, but there is atrophy of the midbrain. So a sagittal T1 image is a great technique where you, whenever you do a patient with Parkinson's, or when you do an MRI with movement disorders, it is very, very important to acquire these 3D MP range images. And when you acquire them, the good thing about the 3D MP range is if you acquire them in axial, you can reformat them in coronal and sagittal, and on the sagittal view, it is very, very important to actually have a deep look into the brainstem and look for any underlying brainstem atrophy. Lastly, let's not forget about Lewy body dementia. It is a neurodegenerative disorder which has similar pathology to Parkinson's, a lot of overlap in the symptoms and in the pathology, and it can present with both Parkinson's symptoms and dementia. So the more dementia it presents, the more likely it has an Alzheimer's presentation, and the more Parkinsonian symptoms it does, it has actually a more of a idiopathic Parkinson's disease presentation. It is the most common, it is actually the second most common cause of dementia after Alzheimer's disease, and in Lewy body dementia, dementia predominates or occurs earlier than Parkinson's type symptoms. And it is important to differentiate Lewy body dementia from idiopathic Parkinson's disease and Alzheimer's dementia. MRI in these patients is normal or non-specific, but you can utilize FDG PET and amyloid PET, which is actually very unique in Lewy body dementia, and we'll talk about amyloid PET, and you can use a DAT scan. So if you look at the PET actually shows decreased metabolism in the occipital areas. And that is a very important finding, because that is a very specific finding of Lewy body dementia. Because in Alzheimer's, there's more of a temporoparietal decrease in atrophy, or temporoparietal decrease in uptake. But in Lewy body dementia, you have more of an occipital lobe hypometabolism. MRI, as we just discussed, is normal. And this is actually the key to diagnosis of Lewy body dementia. You do an amyloid PET. And if you look at a normal patient, the amyloid PET, you can use it with a carbonyl 11 labeled Pittsburgh protein, which is actually not widely available because it's not actually, you actually require an on-site cyclotron to actually generate this radiopharmaceutical. So it's not really that widely available unless you have an on-site cyclotron, which can actually give you the carbon 11. But what is widely used is actually the 18-fluorine fluor beta per, and this is another amyloid agent. And if you notice, the amyloid is normally taken up by the white matter of the cerebral hemisphere, but the cerebral cortex does not actually have amyloid uptake because there is really not much amyloid deposition in the cerebral cortex. But in patients with Alzheimer's dementia or Lewy dementia, you actually have increased uptake of amyloid traces in the cerebral cortex. So you lose that gray-white differentiation, which you normally see. And this is a very specific finding of Lewy dementia and is not seen in other movement disorders. So you can actually use a amyloid PET if you need to diagnose Lewy dementia from other types of movement disorders. So in conclusion, imaging of movement disorders remains a moving target. There's a lot of research, a lot of things unknown, a lot of variability, and we try our best to help neurologists when there is actually a difficult case, but you have to realize that even in imaging, in the early stages of disease progression, imaging changes can be very non-specific. It's only the advanced stages that we start picking up the more specific findings of each disease, where it's on MRI. But obviously, nuclear medicine imaging studies such as DAT scan and FDG PET and amyloid can actually show changes much more early. MRI, since it's more widely available, remains the modality to exclude other pathologies and can show important findings in the atypical Parkinsonian symptoms group. And DAT and PET can always answer specific questions to etiology, but unfortunately not as widely available as MRI. And thanks to everyone. And please let me know if you have any questions. And again, thank the organizing members of this committee for allowing me to talk a bit about Parkinson's and syndrome and atypical Parkinsonian syndromes. And please feel free to ask me any questions. Thank you. Answers in the chat box, and I will not reveal the answers right now. I'll just show the cases, and then I'll go for the answers and discussion in the next set of PowerPoint slides. So this is the case one. We have an axial flare on my left and an axial T1 post contrast on the right. And the question is, what is the likely diagnosis? And we have 5 choices: a cerebral abscess, metastasis, tumor-effective demyelination, subacute infarct, or primary CNS lymphoma. And if you're welcome to put the answer in the chat box, and I'll only reveal the answer in the next set of slides. So, or if anyone feels like unmuting and giving a discussion, that's perfect too. So we can do it whichever way you all like. So we don't need to stick to this rigid format. So I'm going to go to the next case. So the next case is a 57-year-old female presents with facial pain, and what is the likely diagnosis? And I should have actually put a CT also, but this is actually T1 fat saturated image where you actually can see a lesion, a T1 bright lesion in the skull base, and this is the T2, and we have 5 choices. Is this a skull base cholesteatoma, a skull base epidermoid cyst, a cholesterol granuloma, a glomus tumor, or a chondrosarcoma? So this is case 3, and this pattern of enhancement. So I'm not going to tell, we're going to discuss this pattern of enhancement, but these are an axial post-contrast and coronal post-contrast, and there's obviously some abnormal brain enhancement. So what the question I'm asking you all is, this pattern of enhancement is likely to be seen in infectious meningitis, leptomeningeal carcinomatosis, neurosarcoidosis, intracranial hypotension, and mechanical ventilation. And if I'm actually advancing the slides before you all have a moment to actually find out what the answer is, let me know. I can go back to any of the previous slides, or I can just wait for a longer time, because I don't want to rush each individual slide. So let me know if you want more time to look at the image or on the options.
That should be fine. Your timing is good. Perfect. You can move
So,
on.
So I don't know how the current boards are being taken in India, but this is how the American Board of Radiology conducts their exam. This is the format where either they have interpretive questions. Most of them are interpretive questions. There are a few non-interpretive questions, but it's usually a multiple choice question. So we kind of quiz our residents in this pattern. Case 4 is a young female with headache, but no visual symptoms. And all I'm showing is a sagittal T1 image. And this is a sagittal T1 image in which there's actually a pertinent abnormal finding. She is actually 29 years of age. And what is the primary management or initial treatment of this condition? So it's important to identify this condition in this case. And once the case is identified, are you going to treat this case with steroids, venous stenting, acetazolamide, hormone replacement, or blood patch? So I'm going to go to the next one. This is a 25-year-old young patient who had high fever, splenomegaly, and headache. And on a lumbar puncture, there was an elevated opening pressure. And this is an axial flare, sorry, T2, T1 post-contrast. And this is the diffusion image. I'm not showing you the ADC, but the ADC showed a dark signal in this region of the brain, which I'm encircling. So the likely cause of this abnormality is splenial infarct, multiple sclerosis, acute disseminated encephalomyelitis, cytotoxic lesion of the corpus callosum, or lymphoma. So case 6, what is the most likely diagnosis? I have an axial T1 precon. This is axial T1 post-contrast, and this is a flare. And the most likely diagnosis is a central neurocytoma, choroid plexus papilloma, meningioma, ependymoma, or subependymoma. And this is the last case, a 9-year-old girl with neurofibromatosis type 1. And this is a coronal T2, an axial flare, and axial T1 post-contrast. So what do the abnormal signal changes in the basal ganglia represent? Myelin vascularization, prominent Wernicke spaces, low-grade brain tumors, chronic infarcts, or carbon monoxide poisoning. Okay, so I have the answers with me, but so I'm going to share these questions and answers. But if anyone want to have anything to comment on, you can feel free to comment and or put it in the chat box. So so this is the first case, and can anyone tell me what the likely diagnosis was before I reveal the answer?
Chat box answers are there, and majority of them say it's tumor factor demyelination.
Okay, great. So that is the correct answer, tumor factor demyelination. Thank you, Kavita madam. So and why does did anyone put in the chat box, or can anyone tell me why tumor factor demyelination is the likely diagnosis?
Distribution.
So the distribution, I would say does not exclude metastasis or abscess, but I think it's the pattern of enhancement. What is in this?
Open ring enhancement.
Say that again. Sorry.
Open ring enhancement.
Very good. Excellent. Very good. Excellent. So if you look at this enhancement, an abscess and metastasis would have a complete ring-like enhancement, whereas in what is very typical of tumor factor demyelination is the incomplete ring enhancement. The incomplete ring enhancement actually marginates or actually defines the advancing edge of the demyelination. Okay, so if you notice that most of these lesions actually have an incomplete ring enhancement, and that is very, very typical of tumor factor demyelination. And things you really want to, two pertinent things you want to know about tumor factor demyelination is the amount of associated vasogenic edema compared to the lesion is actually extremely low in comparison to metastasis, where the amount of vasogenic edema is much more higher. The second point is most cases of patients with tumor factor demyelination do not have multiple sclerosis. So multiple sclerosis typically does not cause tumor factor demyelination. It is other demyelinating disorders, other more rapidly progressing demyelinating disorders, which are actually present with tumor factor demyelination. So 57-year-old female with facial pain, likely diagnosis. What is the most likely diagnosis based on chat box or anyone?
Epidermoid.
So someone said epidermoid.
Cholesterol granuloma and
Yes,
cholesteatoma.
Okay.
Two answers.
Okay.
Dr. Ishwar says cholesterol granuloma.
Okay, so Dr. Ishwar is correct. It is cholesterol granuloma. So, and the reason why this is cholesterol granuloma is?
It's hyperintense T1, no associated mastoid disease, no
Very
middle ear
good.
disease, no middle ear disease. Typical location for cholesterol granuloma of the petrous apex.
That is correct. So, as Dr. Ishwar Chandra said, this is actually on the coronal, this is the petrous apex. It's kind of a difficult to make that distinction that this is the petrous apex on the coronal, but obviously we have our axial counterpart, which actually reveals the abnormal signal. So a cholesterol granuloma contains hemorrhage. It contains subacute hemorrhage. So it is T1 bright, and on T2 it is also T bright. So a T1 and T2 bright lesion in the petrous apex would be a cholesterol granuloma. A cholesteatoma would not be T1 bright. Remember that the only T1 bright lesion in the petrous apex is actually a cholesterol granuloma. A cholesteatoma will be fluid-like density on T1 and T2. It's when you do the diffusion imaging that it is bright. So given that this is T1 bright, it is not a cholesteatoma. Yes, only T1 bright. I like that. Yeah, only T1 bright. And an epidermoid cyst also is not T1 bright. And none of these lesions are also T1 bright. So I think it's the T1 fat saturated sequence which actually proves that this is a cholesterol granuloma. So this pattern of enhancement is likely to be seen in. So what was the answer?
Neurosarcoidosis.
Very good, very good. Neurosarcoidosis. And what about the other conditions? Why is it very, very unlikely to be the other conditions which we mentioned? What type of enhancement do the other conditions cause? Leptomeningeal enhancement, correct. But there is one choice among these 5 which actually causes, and again, this is actually pachymeningeal enhancement. And notice that there is, all this is pachymeningeal enhancement in contrast to leptomeningeal enhancement, which goes into the cortical cell side. So all these other conditions cause leptomeningeal enhancement, but there is one condition over here which also causes pachymeningeal enhancement, but it's not but it is not the right answer. What is that condition?
Intracranial hypotension.
Correct. So intracranial hypotension also causes pachymeningeal enhancement, but intracranial hypotension causes diffuse, smooth pachymeningeal enhancement, doesn't cause this lumpy, bumpy type of pachymeningeal enhancement. So this lumpy, bumpy, non-diffuse pachymeningeal enhancement is very, very typical of neurosarcoidosis. Lumpy, yeah, lumpy, bumpy. Young female with headache, and the finding I showed was this empty sella. So what is this condition and what is the treatment?
It's blood patch.
So why do, so whoever answered blood patch, why do you think this patient needs a blood patch?
Steroids. Yeah.
So when you see a young female come with headache and empty sella, what is the condition we think about? And these patients can also have papilledema, they can have tortuous optic nerve. So young female with headache and empty sella is from intracranial hypertension. So previously we used to call this pseudotumor cerebri. Okay, we felt that these patients used to have papilledema and they used to undergo imaging because they felt that there was an intracranial tumor mass, but on CT and MRI, there is no intracranial mass. So that's the reason why they call it benign. So they used to call it pseudotumor cerebri, and then they later changed that term to benign intracranial hypertension. And now they didn't like that term also because these patients, their intracranial hypertension is not benign because actually it can actually cause visual field loss and blindness. So now they've actually changed the term to idiopathic intracranial hypertension. So if you actually do a lumbar puncture, they actually have raised intracranial pressure. They actually have raised opening pressure. So it's called benign. It was previously called benign intracranial hypertension, and now we call it idiopathic intracranial hypertension. And the treatment for idiopathic intracranial hypertension is?
Steroids.
So steroids are given. Steroids, yes, steroids is the correct answer, but it is not the primary management or the initial treatment. The initial treatment of primary management is actually to lower CSF production. And which drug here lowers CSF production?
Estradiol.
Estradiol, that is the correct answer. So now steroids, the role of steroids in idiopathic intracranial hypertension is when the patients actually have visual field loss. If the patient actually has a rapidly progressing visual field deficits, then they really give steroids. But in someone who actually has indolent symptoms, the primary treatment or the initial treatment of this condition is actually acetazolamide or diamox. Steroids are given when the patients actually have rapid visual field symptoms. That's the reason why the question says no visual symptoms. Because if this patient came with headache and visual symptoms, then you would probably want to give steroids. But since it's only headache, you give acetazolamide. Okay. Now blood patch. Blood patch is actually done for the opposite. When you have intracranial hypotension, low blood pressure, that implies that there is a CSF leak in the lumbar spine or thoracic spine. And to close the CSF leak, you give a blood patch, but that is a treatment for intracranial hypotension. Hope this is clear. So case 5, high fever, splenomegaly, headache, and elevated opening pressure on lumbar puncture. So the likely cause of this abnormality is infarct, multiple sclerosis.
Number 4.
Number 4, very good. Cytotoxic
Majority says number 4.
Very good. Cytotoxic lesion of the corpus callosum. And we see this fairly common, and it is actually, it has a very peculiar distribution. It is actually confined to the spleen of the corpus callosum, and it has a diffusion restriction, and they actually resolve in 4 to 8 weeks. There's a very good radiographic articles which actually talk about why the cytotoxic lesion which happens in these patients actually prefers the corpus callosum. So it's because of the high prevalence of glutamate receptors in the corpus, in the spleen of the corpus callosum, and these glutamate receptors undergo the cytotoxic. These glutamate receptor cells undergo the cytotoxic edema. But I would recommend everyone to read that article in Radiographics about cytotoxic lesion of the corpus callosum. It can be a spleen infarct, but it's most of the time a spleen infarct would definitely be in your differential, but remember that infarcts in the spleen of the corpus callosum or infarcts or macro infarcts in the corpus callosum are actually very rare because of the rich perfusion of the corpus callosum. Multiple sclerosis typically does not show restricted diffusion. There have been a lot of case reports in the acute or in the very, very acute stage of multiple sclerosis, which actually show restricted diffusion. But if you look at most patients with multiple sclerosis who get imaged, they actually do not have restricted diffusion. ADEM is a great differential, although ADEM typically likes to involve the subcortical white matter rather than the corpus callosum. Okay, between MS and ADEM, it's MS which involves the corpus callosum, but an ADEM which involves the subcortical white matter. Lymphoma is a great choice, but lymphoma would cause mass effect and lymphoma would enhance. So I would not put a diagnosis of lymphoma given that there is no enhancement. The case 6, what is the most likely diagnosis?
5. All of them said 5.
Oh, excellent. Very good. Very good. All of them. And the reason why, can anyone tell me why this is 5?
Like a spotter.
Because of the absence enhancement. Okay, so you have an intraventricular lesion which is arising from the septum pellucidum, and it does not show enhancement. And this is the most common location of intraventricular subependymomas. They occur in the 4th ventricle, and they also occur in the lateral ventricle, and they are non-enhancing lesions, and they can sometimes present symptomatically because of obstructive hydrocephalus. So yeah, so this is a subependoma. Now all these other options, central neurocytoma, choroid plexus papilloma, meningioma, and ependema, all of them enhance. Okay, and you have to be careful on your fat suppressed T1s. On the fat suppressed T1s, it looks as if the lesion is enhancing, but you have to remember that fat suppression in general induces some degree of pseudo enhancement, and that's reflected in the basal ganglia. And last question, 9-year-old girl with NF1. So we see multiple basal ganglionic lesions with no mass effect and no enhancement. So these represent?
Low-grade tumors.
So did someone say low-grade brain tumors?
Myelin
Yes.
vacuolation.
Yes, myelin vacuolization is the correct answer. And so you can get prominent vertebrate spaces in any patient, but prominent vertebrate spaces are usually seen more common in elderly, and they typically, vertebrate spaces do not show bright signal on flare. They actually suppress on flare. So that is the reason why a vertebrate space is not a likely diagnosis. Low-grade brain tumors typically in NF1, where they occur along the optic nerve pathways. They can occur in the basal ganglia, but they typically occur along the optic nerve pathway, and those are usually pilocytic astrocytomas. And even though those are low-grade brain tumors, they do show enhancement. So the fact that they're not enhancing, the fact that they do not occur along the optic nerve pathway suggests that these are not low-grade brain tumors. chronic infarcts typically don't occur in patients with NF1, specifically in NF1, but there's nothing which says this cannot be a chronic infarct. It's just that it is not known to be highly prevalent in patients with NF1. And carbon monoxide poisoning also is not something specific to NF1. And this is a great look for distribution of carbon monoxide poisoning. There's nothing wrong in the distribution. It's just that it's not unique for NF1. And so the answer is myelin vascularization. These myelin vascularization changes can sometimes be T1 bright, and they actually can regress as the child becomes more and more older. These myelin vascularization changes regress, whereas low-grade brain tumors actually remain stable or actually can worsen. So thanks everybody, and this is my family and my two children, Akshay and Sanjana. And I can never forget the next photograph I had took with Kakara Subara sir last year, along with Jyotsna madam, when I was in Hyderabad. So hope everyone is doing well. Thank you, everybody.
Thank you, Dr. Siddhartha. Thank you very much for your
beautiful presentation.
For your efforts. Yes, it's a very nice presentation. And I see one question in the chat box. Somebody was asking about Lewy body dementia. I presume that because you have mentioned about amyloid imaging, maybe they wanted to ask that whether we are doing it in India or not. No, right now we are not doing. We are not using these amyloid tracers yet, I think. And maybe one center in the Bangalore, they're trying to do with the fluor beta pair. And but Lewy body dementia has a very specific appearance on FDG PET, that is cingulate island sign. As he showed, occipital lobes will have hypometabolism, whereas the posterior cingulate preserves its metabolism. So that's where we differentiate between regular Alzheimer's disease, where occipital lobes are spared, but posterior cingulate is affected. So here, posterior cingulate is preserved, occipital lobes are affected. That's what is called a cingulate island sign. That's very specific for Lewy body dementia. So, so there's no need. I mean, if we see that sign, it's very specific for LBD. And any other questions regarding the movement disorders? I don't see any other questions.
Kavita, can I ask a query, please?
Please go ahead.
To both of you, to Siddhartha and you. First of all, Siddhartha, it was a very, very, very great evening today. We enjoyed it. And if you would have shown another 50 cases, we'd be continuing to see without any. That was the interest you have generated. Really, it was extremely very nice. Very well done. Very good beginning also. Now, the doubt I had or clarity I wanted was, can you tell us a flow chart on movement disorders? Can you give us an algorithmic approach that if you're suspecting this, do this. If it's not there, then do this. So is it there or is it not there?
So that's a very good question. Actually, so the institutional policy or the institutional preference actually varies a lot in the management of movement disorders and in the imaging. So it's not something as clearly defined as imaging of multiple sclerosis or imaging of brain tumors. So it all depends upon the neurologist's perspective and how confident they are that these patients actually have atypical Parkinson's syndrome or not. So currently, if you most patients with movement disorders have benign essential tremor, and for them there is actually no imaging. They are treated well with beta blockers, and if they fail beta blocker therapy, they go for deep brain stimulation. Before any patient with benign essential tremor undergoes deep brain stimulation, they will get a DAT scan. That's when they will get a DAT scan, because if the DAT scan is normal, then you've proven again that this patient has benign essential tremor, and their DBS is actually put in the thalamus. The target of the DBS is the thalamus for patients with benign essential tremor. Now, when you assume that this patient has benign essential tremor and you do a DAT scan in the hope that he gets a DBS, and if that shows reduced uptake in the basal ganglia, now you're left with this may be an idiopathic Parkinson's disease. And if you are confirmed, and if you feel that this is idiopathic Parkinson's disease, then the deep brain stimulator is put in the substantial nigra. So a DAT scan is always done for any patient with benign essential tremor before they actually go for DBS. Now let's look at the other patients who are actually known to have who are actually diagnosed clinically with Parkinson's. When they're diagnosed clinically with Parkinson's, no one gets an imaging. I've never seen anyone get imaging. They're actually placed on levodopa. Now, they are put on levodopa for years and years, and then they slowly do not respond to levodopa because of levodopa resistance. And at that time, they do imaging just to actually, they do a preoperative imaging just to make sure there are no red flags or there's nothing atypical before they put the deep brain stimulator. And the imaging they do is an MRI. Okay, so when you diagnose a patient with Parkinson's and you decide that he needs DBS at some point, you do an MRI. But when you diagnose someone with benign essential tremor and you think that he needs DBS at some point, you do a DAT scan. Now, if the patients are actually, I've noticed that many times, at least in what I've seen in my UAB community, it's very rare that someone is actually diagnosed with MSA or PSP, those conditions early on. It's actually, most of them actually have had failed treatment or very frustrating treatment for the first 1 or 2 years. And that's when they actually get an MRI to look for these atypical Parkinsonian syndromes. And if the atypical Parkinsonian syndrome suggests MSA or PSP, then there are probably not, they don't get any more treatment, because unfortunately, these are the poor subset of patients for which neither levodopa works, neither does deep brain stimulation work. So if you're diagnosed with any of the atypical Parkinsonian syndromes based on the MRI, then you don't actually, you just get supportive measurement, no treatment. But right now, currently, I don't know that, I don't think, and I don't know, but I have to really speak to a movement disorder specialist. Once the MRI is negative and you still suspect atypical Parkinsonian syndrome based on symptoms, I don't know if we really push forward for a PET. So that's something which I did talk about in my lecture, that you could.
Our neurologists always do that. Of course, MR is mandatory in all these people, but depending upon what is their clinical suspicion, either these MSA, PSP. Another important Parkinson plus syndromes we see here is CBGD. Yeah, that. So it's, I think FDG PET really very useful in all these, in differentiating these. So our clinicians, they just send for FDG PET. Of course, though the management is not much, maybe except in the early cases, but they do send for differentiating between these three conditions.
So unfortunately, we have the problem, right, that reimbursement, unfortunately, in US is not given for FDG PET in movement disorders currently. That is the major hindrance of doing FDG PET in movement disorders. They are reimbursing for dementia, but they do not reinforce for movement disorders, unfortunately.
Yeah, Dr. Vijay Bhaskar, can the audience unmute themselves and then speak? Because I see Dr. Vikram Lile, who's a senior consultant from Jaslok, who practices who does a lot of DOPA scans and then TRODAT scans and then these Parkinson plus syndromes, FDG. He has a lot of experience. If he can speak.
Yeah, they can, please. They can do it.
Yeah, Dr. Vikram, if you're online, please kindly unmute yourself and then share your experience.
Yeah, thanks, Kavita, and a very good talk from our guest. I really enjoyed it. Yes, our neurologists have really started using this combination of TRODAT or FDOPA along with FDG, and we are finding it as a very powerful combination tool to separate these different atypical Parkinsonian syndromes. The patterns are fairly specific for each of these varieties. And I think cost-wise also, it is not a big issue. and slowly they are coming around to using it. MRI is good, but it does not really solve the problem in a fair number of cases. Your patterns, when they are there, they are there. I mean, there's no doubt about it. But especially in the early cases, I think the FDG patterns are a little more specific for each of these subtypes. And we have been promoting this combination of Trodat plus minus or F-DOPA. F-DOPA is much easier to interpret because Trodat, it's a difficult scan. The patient has to be still for 30 minutes, and invariably these are elderly patients who move. And if you have movement, then it's a nightmare to report or to read most of these scans. While F-DOPA scans are fairly very fast, you can finish them in about 10 minutes and the motion is not a problem. So it's becoming more and more popular now, and the referrals for F-DOPA are really shooting up. And this combination, I believe, in our country is going to be very, very useful to the movement disorder specialists.
Thank you. Thank you, Dr. Vikram, for your valuable comments. Thank you.
And I saw one question in the chat box from Sharath Kumar. He's asking, do you do MRPI index for PSP? And no, we don't do it because we need to really have good MR volumetry analysis for that. And our magnet is not that current or actually it's robust to actually give volumetric analysis of the midbrain to Pons ratio. So we are not doing it, but yes, that is the correct way of actually diagnosing PSP.
I see one comment from Dr. Ishita Sen, who's a senior consultant from Fortis, New Delhi. That's one more center where they have a lot of neuro work going on. And she also concur with Dr. Vikram's opinion that combination of F-DOPA and FDG scans, still their experience also says that in about 75 to 80% of cases, they are able to resolve this differential diagnosis. So thank you, Dr. Ishita, for your valuable comments.
That's one hypothetical question I have got. If I have to ask you one hypothetical question. 3 Tesla susceptibility SW is good for swallowtail sign. Is there any experiment going on 7 Tesla or something where we can pick up better these movement disorders? Do you have any idea about high field strength MR?
No, I don't have any experience on like any 7 Tesla having more sensitivity. I'm sure there are studies out there, but no, I don't have any experience.
Okay, thank you.
Okay, before handing over to Vijay Bhaskar for vote of thanks, I would just like to add one more comment that the idea of starting these webinars with international speakers is one, we are able to know about the advances because they'll be really ahead of us. And then second one, when we are on par with them, let's see where we are to see how we are solving those same problems with the resources we have, and we can just compare. So that's the reason why I think the participation should be more active, and then hope everybody would benefit with these webinars with international speakers online. Thank you, Dr. Siddhartha again, and over to Vijay Bhaskar.
Thank you, Kavita. Thank you, Ishwar. Thank you, Gopi, for lending us your Zoom account. Thank you, Siddharth, for wonderful job. We would love to have you again and again and again. I'm telling you, our residents will love to hear from you many more topics from in the future. So you have got one more topic lined up, I think probably next month or so. You gave us one of your topics. So probably in next 1 or 2 months, we'll have your next topic in next 1 or 2 months. Masudhan Rao garu, you have anything to talk, sir? Masudhan Rao garu, sir.
Thanks, Andy. It's a beautiful presentation and nice cases, and even for the.
Thank you.
Thank you, Dr. Gopi, for all your help and support in this. Without you, I don't think we would have had this. Thank you.
Thanks, Siddhartha, once again.
Thank you. Thanks, everybody.
Thank
Thanks,
you.
Andy.
Thank you, Siddhartha. Bye. Have a nice weekend.
Thank you.
Bye.
Okay, Dr. Bhaskar.
Thanks, Amma.
Thank you, sir.
Thank you very much.
Thank you.
It's a beautiful presentation. I enjoyed it.
Yeah, very nice. And then very nice, good start.
It's a good beginning.
Yes.
Please continue.
Yes, yes, sir. Thank you, sir.